Rajiv.
Thank you. Thanks for having this every year instruction course. I really love being a part of it. And next couple of minutes, I'll be sharing views on the role of anti-VEGFs and steroids in proliferative and diabetic macular edema. The first few slides are more of a revision of what we have learned. Can you go next? I'm not able to. It's not
Can you
working.
see the
Yeah. So there are certain guiding principles for treating macular edema. We'll first tackle diabetic macular edema, then go to proliferative disease. So as we have learned that though it's important, classification of macular edema as a clinically significant, today we classify it more as a center involving or a non-center involving. The glycemic control, control of blood pressure, lipids, anemia all are very, very crucial whenever you are dealing with macular edema. And anti-VEGFs are the first line treatment for CIDME. We switch anti-VEGF, switch to a laser or steroid if it's a non-responder. And the two tests which are very crucial in determining the initial treatment choice and even on follow-up the response of treatment are OCT and visual acuity. It's the best corrected visual acuity, not only the distant but even the near vision. In case of vitreomacular traction and select cases of non-responding diabetic macular edema, vitrectomy does have a role. So that's what the algorithm is all about. So you start classifying it as non-center involving or a center involving. Very recently, last month, we have published that 2 years, if you take a non-center involving and follow them up, a third of them will convert to a CIDME. And the only risk factor is more duration of diabetes. So more than 10 years duration, they are the people who have more risk. Either you can observe or you can even do a focal or a grid. If it is center involving, you look into the vision. If vision is good, like better than 6/9, and the patient doesn't have any symptoms, very elegantly the DRCRNet protocol has taught us that we can watch these patients, no need to treat. However, they have also identified subgroups which can worsen, so to be a close watch on these patients. Vision is poor, anti-VEGF you start with and treat it, and after 2-3 injections, every injection actually you should see how the response is. And if it is improving, you continue with anti-VEGF. If there is less response, you have other strategies to do. Now, as I told you, diabetic macular edema is not a generalized algorithm. There are many patient-related factors which alter the treatment. So if a patient has a recent history of a cerebrovascular event, less than 3 months, these are the ones where you tend to avoid anti-VEGF. You can consider steroids. You can even consider laser. If you see a pregnant lady with diabetic macular edema, it's a very mild edema, good vision, you can watch. Early in the pregnancy, you can think of, and if it's a severe edema, laser, steroid, both are option. However, if the lady comes at the late pregnancy, you don't treat because majority of them will spontaneously recover. If a patient is of poor compliance, again you can consider intravitreal steroids or laser rather than thinking anti-VEGF as the first choice. And if a patient has chronic kidney disease, renal condition associated, you start with anti-VEGF. However, on treatment, besides looking at your macula, also see the EGFR. And if you feel that the EGFR is worsening, you can skip an injection in that visit or switch to steroid. There are certain eye-related factors which also govern the treatment of DME. So if it's a vitrectomized eye and having diabetic macular edema, because the vitreous sump is gone, anti-VEGF may not last for a longer time and steroids become an important one. However, if you are treating with anti-VEGF, do tell the patient he will need more number of injections. If it is diabetic macular edema with proliferative disease, anti-VEGF becomes the first choice, and you do either a same time panretinal photocoagulation. Traditionally, we used to treat only the nasal part, assuming that the macular edema will increase, but with anti-VEGF, we can complete the PRP, or even you can do a deferred PRP. If it's a pseudophakic eye with diabetic macular edema, it's important to definitely differentiate a pseudophakic with diabetic macular edema. Majority of time you'll have both the components, and you can consider steroids as one of the treatment when you have a pseudophakic eye with diabetic macular edema and or a pseudophakic edema. There are certain disease-related factors which can play a role. So sometimes you have this plaque of hard exudates, and these are the ones, as Dr. Kim mentioned, have severe dyslipidemia. So definitely it's important to control it. Intravitreal steroids, they tend to have a little better role in clearing these exudates. However, you must realize that even with that, the vision hardly improves, because once you have this plaque, invariably you will have a area of RP atrophy. And definitely adjuvant lipid-lowering drugs are important. If it's a very poor vision, thicker retina, you tend to go with these newer drugs, aflibercept, and now we have the faricimab. You can think of using those. And when you have these vitreoretinal surface abnormalities, the anti-VEGF response is a bit poor. Though they respond, you have to counsel that they may need more injections. However, if there is a frank traction, nothing will work. Vitrectomy in these cases definitely is a solution. Now we have many newer agents for treating diabetic macular edema, and all of them are looking at improving the efficacy or improving the durability. Efficacy is more reduction of central subfield thickness, more improvement of BCVA, early resolution of edema, and having less non-responders. And durability is more longer duration of injection-free period, minimum recurrences, less injection visit, and less monitoring visits. And the newer drugs, like now we have faricimab, and we'll soon get the Eylea HD, the 8 milligram aflibercept, they will be probably one which will be increasing the durability more. Switching gears to the next, the proliferative disease, still laser panretinal photocoagulation is the mainstay as far as treatment of PDR is concerned. This were the classic diabetic retinopathy study, and very nicely it had shown that it reduces the risk of severe vision loss by more than 50%. And they went ahead following these patients for much longer period. So we can see more than 15 years, the same cohort of patients of diabetic retinopathy study, when they followed, they still found that 42%, they still retain 20/20 vision. So definitely laser is not the early, even after 20 years, it is showing its effect. And 84% retained 6/9 vision or better. So we also tried looking at what happens in Indian population, and we had this big cohort of people who had PRP, and we followed them more than 10 years. And we found a similar results. Nearly 57% of them had a better than 6/12 vision. And we also tried looking at how many of them needed vitreous surgery, only 1/3 of it. So definitely PRP seems to work well. There is no substitution for panretinal photocoagulation. It's a 20-year follow-up. So definitely it works well. So after 3 decades, is there any need for change as far as that PDR is concerned? Yes, we think that can we have better anatomical outcome than what, because seeing this type of a picture and seeing a retinitis pigmentosa with lot of pigments in the periphery, both look similar. So definitely if we can have a better anatomical outcome, can we have a better functional outcome? Can we have less adverse effects or probably less progression of the disease and more economical? So let's see whether anti-VEGFs could achieve that, because there are a lot of trials which came showing that it can be used for proliferative disease. So the 2 major trials were the Protocol S and the Clarity study, and they did find, if anatomically, Protocol S 5-year follow-up found that it's same. The risk of the neovascularization was similar as, just 2 minutes more, in both PRP and this, and Clarity anti-VEGF had more neovascular regression. Functional, to the surprise, we thought fields would be reduced in PRP, but field loss was seen even with anti-VEGF. That means disease still progresses, the CNP areas still continue to form, and they cause the scotoma. Side effect rates were similar, progression also it is similar. So definitely, and cost, we know injection cost is much high, so probably anti-VEGF is not an answer. And the major concern is the loss of follow-up, and in protocol as only 60% came. And they did a subgroup analysis to find out those who were lost to follow-up, what happened to them. And they had poorer vision, they had more patients with tractional retinal detachment, and they had more rubeosis. So you must keep in mind, if you have a very compliant patient, a very mild disease, and you are thinking of using, I have a couple of patients on monotherapy, on anti-VEGF, all these criteria, definitely think of using a lone anti-VEGF, otherwise definitely PRP is the solution. So just to summarize, diabetic macular edema, anti-VEGF still is the first line of drug. Steroids are effective but are in a very selective group. The newer pharmacotherapy are all increasing the durability, and we will see soon our patient visiting us less often. PDR, PRP still is the mainstay of treatment. The patient selection is crucial if you are considering anti-VEGF as monotherapy, and definitely there is role of, I've not covered, before diabetic vitrectomies, we do give anti-VEGF, it has got a definitive role. Thank you very much, and I would like to invite all of you for the 6th Retina Summit, which is on with ROP in July 2024. Thank you very much.
Thank you, Rajiv. Please wait. Can Dr. Sangeet can come and start his first slide, probably. In between, we will ask you some questions.
Please.
Yeah, the one thing which it is very clear, and this thing really it do not require any further clarifications, but I want one area where you said early nephropathy and anti-VEGF avoidance. Can you a little bit more clarify about it?
This came, I think, in 2022. There was this nephrologist. So there is no evidence. It's more of a consensus statement from the Nephrology Association, which suggested that if you use anti-VEGF, it can, like regular use can reduce EGFR. And they suggested that probably the newer drugs or alternative drugs can be used. So there are no evidence as such suggesting that EGFR reduces. But if on treatment you feel that the nephropathy is worsening, it's not a bad idea to give a gap, take more control, because even we know that we want to control nephropathy for diabetic macular edema.
Yes.
So not a bad idea to give a gap and then start again.
You say regularly GFR should be done, or you want
I
any
told
other
eGFR.
parameters?
eGFR is estimated GFR. For that you only need a serum creatinine.
Yeah.
So serum creatinine, if you have done, you can calculate a eGFR, and that is, so this was again one study with Dr. Mohan we did, that if you are dealing with diabetic macular edema, it is the albumin creatinine ratio, that is microalbuminuria, becomes more important parameter. In proliferative disease, it is the eGFR, which is something which you must monitor.
Any level would you suggest that people should be careful about it?
It's not the level, because eGFR is used to classify the chronic kidney disease. So less than 20, so you don't want them to go down, because they will change from a mild moderate CKD to a severe CKD. You don't want that to happen.
Thank you very much,